Now let's move to another important part, immune reconstitution and post-transplant infection. As you said, post-transplant infections remain a major cause of morbidity and mortality. What are the most critical barriers to improving outcomes in low middle income countries transplant programs?
So, as I already said, that infections are the major problem in these sort of transplants, and they are mostly multi-drug resistant. So, in the first stage of transplantation, where we have no neutrophils, no monocytes, no lymphocytes, we have destroyed it all to get the donor cells in, and the donor cells take 15, 20, 30 days to start working. In that period of 2, 3, or 4 weeks, we are completely vulnerable. As a patient, we are completely vulnerable to any attack by any bacteria. And if it is multi-drug resistant, we are 100 times, 1,000 times more vulnerable because of lack of appropriate antibiotics to deal with it. Now, what we did in that situation when we first faced this problem with a very high mortality, 30% mortality because of infections, we started using donor neutrophils. Neutrophils, as I said, are very short lasting. They live for 2 or 3 days. They would die off. So we plan to give multiple infusions of donor neutrophils or donor granulocyte infusion, as it is called, before the infection sets in, to tide over this period where there are no neutrophils or no cells in the body. And with this approach, we have thankfully been able to address the initial problem of multi-drug resistant bacterial infection and deaths happening because of that. But then comes the next phase where you have got your neutrophils back, but you don't have your lymphocytes. And that is the stage when viruses start attacking the body from within. Cytomegalovirus, Epstein-Barr virus, adenovirus, and from without or the outside, all the whole host of respiratory viruses, influenza, parainfluenza, you name it, there is all. I mean, you are just surrounded by these viruses at that time in the most vulnerable period. So a very strict isolation within the system means you don't go out and invite trouble. So that's what our advice to the patients, that stay out of crowd, wear a mask, wash your hands, like, all the COVID protocols that COVID has actually made our work easier. We just tell patients now that just follow the COVID protocol. So that way you at least try to prevent the infection viruses you are getting from without. Now, what happens from within requires a vigilant monitoring. We monitor CMV, EBV, adenovirus, and try to prevent them from getting to a stage where they can cause mayhem in the patient. Now, how do we do all these things in a resource-limited setting? So these monitorings are largely based on polymerase chain reaction or PCRs. Now, PCRs are not very expensive tests at current time. They can be developed in-house. There are kits available. All it needs is doing it at a regular interval to detect any problem that's coming up. It is more because of not doing it than the cost that the problems happen. So once it happens, the cost of antiviral therapy is, spirals out. So the main thing here is prevention. Prevent getting a bad respiratory viral infection, spread the reactivation, stop the reactivation of cytomegalovirus or Epstein-Barr virus very early on so that they don't become a problem. So the next phase is spent on that phase. And mind you, in humid tropical country like India, adjoining places, also in Africa, I would say fungal infections are a problem. Especially in India, there's a lot of pollution in the winter season, and we get a lot of patients coming in with fungal infections. So it's a constant battle with pathogens around us till the immune system develops to a stage where it can take care of itself to an extent. So prevention, monitoring prevention, that is the way in low middle income countries, rather than putting a patient on a drug which would reduce the chances of getting infected. Because a constant, exposure to drugs, I don't agree with, because it again leads to resistance of the bugs to that particular drug, and it increases the cost pretty, steeply. So my approach in a LMIC is to prevent, monitor, and treat at the earliest possible time.
Okay, so how can immune monitoring and immune reconstitution strategies be optimized in settings with limited laboratory resources?
See, one need not do a lot of tests, okay? What you need to do is a CD3, CD4, which are basic T cell subsets. NK cell is marked by CD56. So one flow cytometry run tells you how much of B cell you have, how much of T cell you have, and how much of the CD4 T cells you have, which are basically the protective cells. And one can also look at B cells in the same setting with looking at CD19. So if we are doing these tests monthly for at least the initial 6 months and then increase the frequency, we get an idea about the immune system of the patient, how it's recovering, how vigilant we need to be, and how intense our monitoring need to be. So a lot of the times when the immune system is well developed and patient gets an infection, we are not that intense with the treatment. We leave it with the immune system to handle it to an extent. So the monitoring of the immune system is very important. It is not done routinely in any center as such, because there is a lot of reluctance amongst doctors and patients alike to undergo regular monitoring. But what regular monitoring gives us is the understanding and the bandwidth to deal with situations based on how our body is going to cope with an infection, how our body is going to cope with a malignancy. Means if I get a well developed immune system, I get a good graft versus leukemia or an anti leukemia effect from that as well, apart from dealing with viruses, etc.
Thank you. So, what lessons from your experience in India could be applicable to African and other low middle income country settings?
So, as I said, that we have to look at transplantation, especially half match transplantation, as something we would do with the aim of curing. I'm taking the paradigm of malignancy, that to cure the leukemia, but at the same time not kill the patient in the process. So to do that, we have to be very vigilant, very intensive upfront. Means we have to create a situation. See, to the extent what we do is we sort of try to understand the patient's home situation. That after discharging the patient, what is the home situation going to be? Does he or she have a single-use toilet? Can there be an isolation at home? What sort of cleaning methods would be implemented? Which seem very mundane for a transplanter. But these are very important things for us to implement before we go ahead with the transplant. Who is going to be the caregiver? How competent is the caregiver? How well educated is the caregiver in terms of what we... So the caregiver is with the patient for say 30 days of transplant. And in those 30 days, the caregiver is taught all the nitty-gritty of how to take care of the patient once the patient is discharged, to take care of the Hickman line or the central line which is there in the patient once the patient is discharged. So by doing that, you reduce the dependency on the healthcare system to an extent. You reduce the cost incurred to an extent. A lot of the monitoring can be done from the home situation as well. So, if we can reduce the visits or travels to the hospital, then the chances of exposure to hospital or the nosocomial infections is reduced as well. So it's not just about doing the transplant successfully in the first 30 days. Of course, that's there. That's the crux of it. But until and unless we can work around it, that how we can reduce the complications after transplant and how we can do it preemptively, means take steps before the transplant itself so that it's effectively implemented. That's the, I think, key to doing transplant in LMICs and Africa, that we have to create an ecosystem in where the caregiver and the caregivers, the home situation, offer the patient an environment where they can be safely nursed, managed, as well as the mental well-being being maintained without multiple hospital visits, where the nurses or the doctors can visit the home and take care of the patient, etc. These are the models that we are trying to develop, and these are the models that we have to work in our countries to make it cost effective.
Yes, I completely agree with you. And now let's move to an important part you mentioned earlier as one of the barrier is the cost and its reflection on the equity and sustainability. So what innovative financing or structural approaches have helped improve affordability in India?
I mean, I would say that the situation in India has drastically changed over the last 10 or 12 years. I mean, there are a lot of government schemes which are helping the patients. Um, but apart from that, I mean, see, for example, patients who are below a certain income limit, they get straight away, something like 4,000, 40,000. Yeah, something like $5,000 in US dollars, $5,000 straight away from the Prime Minister's fund. So another $5,000 from a Chief Minister's fund, and so on. So there is a very good network of the government, insurance systems, which can help the patient, which are not like, it's advertised or out in the open, but those who are working in this field are well aware of it and they can utilize it. But apart from that, because India is becoming, I mean, the population is becoming overall richer, and there is a tendency to give also. So there is a thing called crowdfunding, where you put up your situation that, look, my child has got so and so and I need a transplant, I need so much money. Crowdfunding pours in, and a lot of patients get treatment simply through crowdfunding. So a lot of treatment can happen through all these things combined, with not putting undue financial pressure on the patient and the family. So this thing is developing in India. But it needs a more structural approach, I think. These are very scattered. They need more structural approach. Now, the same thing can be replicated in, Africa as well. That I know that, for example, I have, friends and colleagues in Nigeria, for example, um, or Uganda, where there are people who are ready to help, treatment of other people. It requires a structural crowdfunding platform which can be utilized to fund, children who are undergoing transplant. And at the same time, there has to be lobbying and pressure on the government to subsidize such programs, particularly for children who are being treated with a curative intent.
So you see that government uh, has role in this context for
Yes.
implementation of bone marrow transplantation into national cancer control plans. So, what policies are are most urgently needed to expand the transplant access globally in general?
So, as I said, that we have to break the national barriers to an extent for achieving this. So, I mean, for example, I myself am very keen on helping and assisting centers in certain countries of Africa which have approached me to train manpower, to help them develop the infrastructure with technical expertise, because this is possibly the third transplant unit that I am supervising infrastructurally to build. So, with a fair amount of expertise in how a transplant infrastructure is to be developed, this is something of an expertise I'm ready to, share with anyone who is keen on, accepting and would like to implement this in their own setup. Now, as I said, that there are certain very stringent requirements for a transplant unit. And if we can have that capital investment upfront, see, there is a tendency to cut the capital investment and say that, okay, won't do that much, we'll do so much. What happens as a result is the patients are more likely to get fungal infections during the hospital stay. And the treatment of a fungal infection is 100 times that of the cost of having spent that money in the infrastructure. To have a good PCR setup and preventing cytomegalovirus or Epstein-Barr virus early reduces the cost of treating these diseases once they're developed by 100-fold. So we have to understand that the upfront expenditure and the concept that prevention, monitoring, and spending on infrastructure which would achieve us to have less infection during and after the transplant, training the ecosystem around the patient, not just the doctors and nurses, to adapt to this system, which we have successfully done to an extent, where the patient's relatives, I mean, the father, the mother, the aunt, uncle, whoever it is, they are so well aware, they are so vigilant about the do's and don'ts, and they are the ones who sort of educate the next patients who come in, that this is how you have to develop your ecosystem. So it's a springboard like thing that one is getting transferred to other. So it's an infectious transmission of caregivers' knowledge from one to the other.
Completely agree with you. We should understand these points and transfer these into policies that will serve patients and their families. Now let's move to another part, research and capacity building. What are the priority research areas in pediatric transplantations that require global collaboration?
See, for any transplantation, particularly pediatric, we have to be conscious about the fact, and this is something I keep on saying, that when we are transplanting a 2-year-old or a 5-year-old and curing the disease, he has got 50 years, 70 years, 80 years ahead of him or her. So what matters is how a child grows, how a child's brain would develop, that is his cognitive abilities, whether his hormonal system, endocrine system would work perfectly or not, which includes the reproductive system. So these are the concern, apart from curing the leukemia, to have a normal growing child with a normal reproductive system, normal cognitive behavior, and you know uh, with a bright future where he or she can contribute to the society should be how we should look at pediatric transplantation. Now, to achieve that, we have to understand that the drugs we use for chemotherapy or radiotherapy um, are causing these problems, apart from graft versus host disease, which happens later. So, how we can reduce the toxicity of what we call conditioning, especially in children, with respect to all these things, I think should be the key area of research. The second part should focus on how we prevent chronic graft versus host disease, because that is the other, devil in the game. So if a child develops chronic graft versus host disease, the quality of life is affected very heavily. So what we often land up is that I have a child, for example, right now, who before he came to us at the age of 2.5 years had a leukemia in the brain. He was given radiation to the brain, which we particularly avoid in younger children. And he's cured of the leukemia. He's now 10 years post transplant, but for the last 5 years, he's got refractory seizures as a consequence of the radiation he received. So, despite being cured of leukemia, despite being growing well, etc., his life is ruined by this uh, having episodes of seizures or fits continuously, which is impending his normal life. So I would say that that is where the current research as far as pediatric transplantation should focus on. Curing the leukemia would happen whether it's a child or an adult. The approach would be the same. It won't differ from an adult to a child. What would differ from an adult to a child is how the next 50 years of the life is going to be modeled, how it's going to develop. What would the child be like 10, 15, 20 years down the line? So that as a society, as an international group of researchers, we have to focus on.
So, how can low middle income center in the low middle income countries strengthen research capacity while maintaining high quality clinical care?
See, research always need not be um, cash intensive. So, research is all about understanding the problem and trying to address the problem which would be affordable and globally applicable. So, I'll give you an example that we say that thalassemia gene therapy works, sickle cell gene therapy works. But what percentage of patients of thalassemia or sickle cell anemia across the globe can really even think of having a gene therapy which costs $1 million? So is this solution an apt solution for this condition? My answer is no, because the 99% of the affected children can't even go anywhere near it. So a solution or research has to have this understanding and applicability within it. So what I believe that any government should dedicate a certain percentage of its GDP for research. And the research priority areas have to be decided. Like in Africa, malaria, tuberculosis would be a priority area. but so would be a sickle cell anemia. Now, sickle cell anemia cannot be dealt with just by saying that I will take care of the painful crisis as and when it happens. That cannot be a solution. So we have to look at a cure. And if you are looking at a cure, it's either a transplantation or gene therapy. So if you are looking at gene therapy, it's now out of reach of, as I said, 99% of the population. What is possible, what is affordable is a transplantation. So how we can make a transplantation affordable and possible for majority of the sufferers of this disease is what our work should focus on. So research has to be, as I said, specific, disease specific, population specific, and the application has to be across the board. That is how the LMIC research have to be designed. Unfortunately, what is happening right now, not just in the West, but in India, government spends billions of dollars on research. So today, the molecule X is, there is a publication in a big journal, whether it's Cell, Science, or Nature, that a molecule X can, change the pattern of certain cancer cells, and they will be susceptible to killing by an X agent. Now, the next $100,000 would be spent on trying to replicate that in the LMIC countries, because they want a validation from the West. They want to work on those lines and get publications in those journals. And that is a lame attempt at research. Your problems are different. If someone finds out that problem, you can apply it to your setting. But you need to find a solution to what is impending in your hands right now. So that is how I think LMICs should approach right now.
And how role can the international partnerships play in improving transplant outcomes worldwide?
As I said, that it is experience, expertise, and technology-driven discipline. So technology sharing is where the international partners can, step in. Say, for example, next generation sequencing, which is testing for genetic mutations or testing for whether the genes are working properly or not, etc., is the fundamentals of cancer diagnosis and treatment right now. Now, to take it in isolation is very expensive. Now there are sort of, atomic reactor-like setups in various places in US where they're running 100,000 tests a day. How we can integrate with that, I'm just giving an example, how we can integrate with that without increasing the cost on ourselves is something that we have to look at, because the setup is already there. To develop the setup from scratch with us is going to be very capital intensive. It's a manpower intensive thing. So that's one way. The second is, and what I keep on saying, is manpower training, enabling the local population, the local experts. Say, for example, training scientists who are working in Africa in these procedures, training doctors in Africa who are treating patients in these procedures, giving them enough exposure and constant hand-holding after that for a duration until they gather the confidence, the expertise to deal with it themselves, and constant exchange of knowledge. So if we put walls around the knowledge that we gather, state-wise, country-wise, region-wise, then we can never develop. I mean, I have a very simple question that we are trying to find a solution for, different cancers. We have got CAR T cell therapy, etc. why have we not been able to solve the problem of malaria or tuberculosis until now? We know where the problem is. Why have we not been able to solve it? Because we have not involved the local people in this problem. We have tried to sit in Washington, New York, and London to solve the problem of malaria and tuberculosis, where the people who are on the ground actually know what the problem is. They are the ones who have to be empowered to do the research. So that is where the problem is, and that is what the international community has to address.
Yes, completely agree with you. Now let's move to another important part, the future of cellular therapy. CAR T cell and advanced cellular therapies are rapidly evolving. So how realistic is their integration into low middle income country health systems in the next decade?
See, the thing is, a couple of years ago, I would have said it's very difficult. But a couple of Indian groups, scientists and entrepreneurs have actually, cracked the code, you can say, to an extent. They are producing, CAR T cells at 1/10 the cost it is that there in the US or UK. And when I say crack the code is that of patent. So US companies take patent of viruses, they take patent of molecules, and the cost just soars up. It goes out of the roof completely. Now these Indian scientists are producing their own viruses to create CAR T cells. So once they have started doing it, the cost has reduced drastically. And I think in near future, this will develop further, and the cost of CAR T cell therapy would come down further once there is more competition. The cost would come down. But do I think that CAR T has an answer to all the problems? The answer is no. CAR T can only address, I would say, 10 to 20% of the problems in malignant diseases. It is an innovative technology which can be utilized for a group of diseases, which can be utilized in very specific situations. And even then, in many a situation, after a CAR T cell therapy, one has to undergo an allogenic bone marrow transplantation to achieve a cure, because CAR T cell can control the disease, get it eradicated from the system for the time being. But most of the time, it's not curing the condition. And the second problem that's happened with CAR T cells, it's gone into the domain of the big pharmas too early. Before it has developed as a safe product, it has gone into the hands of the big pharma, who are immediately commercialized a product which had a lot of toxicity. So the we have rather than looking at how to reduce toxicity of CAR T cells, we have gone into producing more and more CAR T cells of different types under different banners. So the safety aspect has been sort of, ignored to an extent, so that it produces a lot of toxicities. It's not a non-toxic procedure. So if transplantation has got a complication rate of 10, CAR T cell therapy would have a complication rate of 5 to 6. So we need to reorient ourselves to how to look at a problem. Um, it's not about producing more and more. It's about producing enough, but producing it safe. So if it is not safe, the cost of dealing with complications brings the cost again to an extent which doesn't make it affordable. So I might produce CAR T today at a 1/20th, 100th the cost of that it is produced in the US. If I cannot make it safe, I don't think I've done my job. So how we look at the problem is how we get the solution.
So you find the problem in the development or the toxicity of these therapies itself. Not there is a proper management in regulation or technical or infrastructure. The main problem mainly in the toxicity that we see with these therapies, right?
Yeah, I mean, see,
No,
we have a godlike capacity right now. What I want people is that we have, I mean, God is testing us by giving us His own weapons, which is to alter genes in our bodies. So, to the extent we can clone a human being, we can produce designer babies, we can do anything with the genetic engineering capacity we have right now. And we are trying to, so I'll just tell you briefly what CAR T cell does is in a normal human immune system, the T cells are educated through the HLA system of the own self, that this is my own HLA and my own HLA system will present the antigens or the peptides from a cancer or from a virus or a bacteria to the T cells. And there are certain T cells which are designed to attack this particular bacteria or this particular virus, and they will grow at that point and kill the bacteria or virus or the cancer. Of course, when this system fails, we get infection which cannot be cured, we get cancer which cannot be cured. So the system was developed where this whole thing about presenting the peptides or antigen to the T cells is completely done with. We are putting putting genes one after another, whereby the antigen of the cancer cells can directly be attacked irrespective of presentation of the antigen. It need not be presented to the T cells. The T cells by themselves would go and attack the tumor cell. Now, nature had not created us this way. Nature had created a graded attack system and a graded retraction system after the attack. Now, when you abrogate this system, when you override this system, you lose control over that. And that is why we get so much of reaction after CAR T cells, which we call CRS, cytokine release syndrome, where patients can even end up in ICU, or we get ICANS, which is a neurological toxicity where you, even now after 10 years, we don't know the reason why it's happening. But the reason is very basic, that because we have abrogated a natural law of the immune system, which might be fine to control the cancer for the time being, but it can also cause this havoc at the same time, which we still don't understand.
thank you so much. Um, Looking back at your career in transplantation and cellular therapy, what has been the most transformative development in the field?
See, I have, as you rightly said, I mean, my career in transplantation started in early 90s. And at that point of time, we were just understanding that the T cells from the donor can actually cure the leukemia in the patient. And we were starting to use less and less toxic chemotherapy to condition the patient for transplant. So that is where I started my journey. And that was a paradigm shift at that time, that we called it a reduced intensity conditioning or non-malablative conditioning, where we don't need to destroy the entire marrow cells of a patient. We just need to do enough so that the donor cells can get in and do the job. So those were very exciting times, and that was the first paradigm shift which I witnessed when I started my journey. The second, I would say the most important paradigm shift has been with the development of haploidentical or mismatched family donor transplantation in the field of transplantation, because now everyone can have a transplant from within the family, because the parents are half matched with the child is half, we are half matched with the children. We are 90% of the time, if not fully matched, we are half matched with our brothers or sisters. So in a given family, there will be always 4 or 5 donors hovering around. And what our group we have tried to perfect or develop is to select the right donor amongst them. If it is leukemia, it's one type of donor. If it's thalassemia, it's a different type of donor. So that is how we have tried to understand the natural cellular immune system and its interactions to best deal with transplantation in a given disease situation. So to me, haploidentical transplantation is the biggest development, the way it is right now with the use of post-transplantation cyclophosphamide and abatacept in our hands. But saying that, I would say that genetic engineering is the other development which has taken place, which alongside it being very, very exciting, I would say that it is uh, extremely scary, because human beings are not responsible animals. They have never been. Then, if that was the case, we would not be having World War I and World War II. We would not be dropping the atom bomb on Japan based on a science which was created in Niels Bohr's and Einstein's lab. So we utilize science to kill 100 million people. So science in wrong hands is very scary. So we have got this capability right now to either cause wonderful things or cause destruction and mayhem. That is the way science is placed, biological science is placed just right now.
Yes. So, based on your experience, what advice would you give to young hematologists in low middle income countries who aspire to build transplant programs?
This is the same I tell everyone across the globe. The first thing as a transplant physician or even as a doctor one has to do is put the patient at the center of the whole construct. Now, if I'm trying to develop a transplant program, who I'm developing it for? So who is the patient over here? The patient and the family is my first priority over there. So that's the first thing. Now, if I'm going to develop a transplant program where a majority of my patients are going to be of sickle cell anemia, I have to develop it that way. If I'm developing a transplant program where majority are going to be thalassemia, majority are going to be AML or ALL, so I have to develop it that way. So it has to be very patient-centered. The need of the patient, the need to develop the science according to the need of the patient, to develop the infrastructure according to the need of the patient, to develop my training according to the need of the patient is very important. The second most important point is mentorship in this. So we cannot develop as transplanters without mentors. To have a mentor in this field is very, very important, because this is a very nuanced and intuitive field of science where arts plays a major role. The art of decision making, the art of preemption, the art by which we can forecast a problem and act before the problem happens, which I was telling you all along, that prevention and monitoring, how do we do it? We cannot do it out of the blue. We cannot do it raw. We need mentors. So the mentorship can happen in real time, mentorship can happen virtually, but we have to have a mentor to be a successful transplanter in a transplant program. And we should never think of a transplant program as a singular person-driven program. We have to build an ecosystem of doctors and nurses and social workers, psychologists, and what we call the housekeeping personnel in our setup. All of them put together would draw a successful transplant program. So the job of a transplant physician is not just to know about conditioning and GVHD prophylaxis. They have to know about what is a transplant unit, what are the requirements of a transplant unit, construction-wise, engineering-wise, maintenance-wise, It's infection control wise, what cleaning materials should be used and when and how and what frequency, what should be the water like, what should be the air like, how frequently you monitor, where is the time you would intervene and say that, okay, I need to change this or change that. That whole thing comes in. So this is not a requirement in the West. There are individuals who would deal with all these things individually. When I started a transplant program in India, I came up with this expertise that I had trained myself in the HVAC system in the UK to come and actually, as a doctor, advise on what should be the HVAC system or the air handling system for a successful transplant unit. What paint should be used, what material should be used for flooring, what material should be used for the walls, for the ceiling, how do we seal each place. Who does it as a doctor? But to do it in a LMIC, you have to do it. So it has to be very global and very comprehensive, out of which your core medicine is definitely a part of it. But as I said, without understanding the entire ecosystem, a transplant program won't be successful.
Um, Now we reach the last part of our interview, policy message. So as we approach International Childhood Cancer Day 2026, what message would you like to share with global policymakers about the importance of investing in pediatric transplantation and advancing therapies?
So the premise on which I would start this conversation is this, that the future of mankind are children. So if we cannot save and support the children, we do not have a future. So what I told us a little while back, that our focus should be on saving the life of every children. I know that the nature doesn't allow us to save every life, but that should not stop us from trying to do it. And in an attempt to do it, we have to make sure that the child grows up as a normal, beautiful adult. Then only as an individual and as a society, we will benefit from all the approaches. So the policymakers will have to understand the requirements of a pediatric transplantation. It's not just about giving a drug and giving the cells and getting rid of the leukemia at the end of it. It is to, at the end of the day, to have a beautiful growing child who grows up to be a wonderful, productive adult who is of wonderful benefit to the society. So if policymakers understand that investing in these things is going to end up in that sort of a goal, then I'm sure they would think about investing here. It is not just about give money and do a transplant and go to the next one. So it's like planting each flower and watch them bloom. So you have to give the fertilizer, give the water, have the sun, have the rain, everything in a way so that 100 flowers can bloom in every part of the world.
Thank you so much, Professor Suparno, for sharing your expertise and the insights with us today. Your reflections on transplantation, immune reconstitution, and advancing cellular therapies highlight how innovation and scientific excellence can transform outcomes for children with life-threatening diseases. We are deeply grateful for your contribution to the PAPERI Bright Mind series and for your leadership in expanding access to life-saving transplant care. Your work reminds us that progress in science must always move hand in hand with equity and global collaboration. Thank you so much.
Thank you. Thank you so much.
To our audience, thank you for joining us as part of the International Childhood Cancer Day 2026. We invite you to continue following the Bright Mind series as we share perspectives from across regions and disciplines. This conversation is part of the PAPERI Bright Mind series for the International Childhood Cancer Day 2026. Thank you for watching, and we hope these discussions inspire continued cooperation and action for children with cancer worldwide. Thank you so much.